welcome back, everyone. I hope you all enjoyed JV Sax. I was in here jamming. So. But now we'll go ahead and move into our second panel with our first speaker for the Assembling Tools for Health Literacy. Our first speaker is Penna. Kat has over a decade of experience in health services research. She's currently a part of the research team at the UL Picard Center. Go Cajuns again. Her work focuses on early intervention and prevention programs. So please welcome Penna to the stage.
Hello. Thank you all so much for letting me be part of this today. I'm excited to get to chat with you all. I enjoyed so much the previous panel and speakers. I stumbled into the world of health literacy in the early 2000s. I finished undergrad as a communication major, had plans to go to law school, and was living up in Shreveport, and started working at the medical school there as a grant writer and editor, and I thought it was just going to buy me some time to figure out my direction in life. And I, by pure providence, started working with a woman named Terry Davis, who was an early pioneer in the field. So this was, again, 2005, 2006, and she was working with a nationwide group of researchers that were trying to talk about, which Maggie talked about this, the first panel talked about this, but this large concept of the definition of health literacy, how it is something that is totally distinct and separate from functional literacy. It's not something that you equate with education level or ability to read and write. It's bigger than that, and there's lots of other factors to it. And so through my work with her, and then I went on to study more health behavior and communication in public health in Birmingham, and then ultimately ended up with a really great team of researchers at Northwestern in Chicago, just looking at, again, the multifaceted nature of the idea of health literacy. One of the first panelists talked about how the idea has been around for a long time, but it didn't really make its way into the lexicon and the common language for a lot of practicing clinicians until the early 2000s. The Department of Health and Human Services, every decade, many of you probably know this, there is a large publication called Healthy People, and they basically look at health indicators across the country and identify areas that are in need of improvement and are in need of a lot of focus, and then they set these actionable and measurable goals for the next decade to work on these health indicators, these areas that are needing help or whatever. Well, so in Healthy People 2010, which was in the early 2000s, they said there's this idea of health literacy, that this is different from your functional reading level, that there are these things like numeracy skills, trouble solving, problem solving skills. Well, by Healthy People 2020, it said, it sort of expanded the definition even further, and then finally in its latest iteration, Healthy People 2030, which was released about 6 months ago, it actually then separated that definition, like it was mentioned, to health literacy being someone's ability to obtain, use, and act on health information for themselves. That's personal health literacy, but also organizational health literacy. And that was an important distinction and shift because it allowed for some shared responsibility on the part of the organizations providing our information. Insurance companies, health insurance companies, pharmacists, clinicians, referencing even the front desk people. It's not just on it's not just incumbent on the individual to obtain this information. There's also a bit of shared responsibility there to make every effort to implement several of the suggestions that have already been mentioned this morning in how we talk to patients. So in kind of looking at overall aspects of messaging and communication, I sort of thought about it in a couple different ways. So one, it's been talked about already, but there's text and language communication that we talk about, and some of the very clear things that clinicians can do and be conscious of and aware of. And this also does include people like your front desk staff who are scheduling with patients, or people giving post-op or pre-op instructions. Anyone who's giving information like that. Be sure that your language is clear and concise, and a lot of times they make a big kind of buzz phrase is, what's the need to know and the need to do? Again, that was referenced earlier, but essentially, I don't necessarily need to know everything that's going into this treatment. I need to know what I need to do. I need to know what I need to do and what I need to not do. So 2 big projects that I just wanted to mention is one that was done with the American, it was ACP, so American College of Physicians, but it was a diabetes study, and we basically created a book for diabetes management because there were so many rising costs with bad health outcomes for people trying to manage diabetes on their own. And it's no wonder. There's a lot of things to consider when you're diagnosed with diabetes, not least of which being when you get a diagnosis like that, as mentioned in the video, it's an overwhelming idea. You're never going to be able to have a funnel cake again, or you think of these dramatic scenarios, and so sometimes it just feels very overwhelming. Well, we worked on this guide, and we chose to use, in a lot of situations, we chose to use pictures that were universal. If you cup your hands, this is an appropriate serving size of rice. If you can make a fist or use a deck of cards, that's an appropriate portion of meat. A potato, a baked potato, a good size to compare that to would be a computer mouse. And so we used it with over 2 million patients nationwide and followed a lot of health outcomes, and people were having a lot of improvement in actual outcomes, A1C levels going down. The other key element to this booklet, we've talked a lot about patient engagement and getting them feeling that efficacy and that motivation to be responsible for their own health. So in the guide, it would offer very simple suggestions. So instead of trying to set a goal with a patient of, by next time I see you, I'll lose 5 pounds. Well, you can't guarantee that you're going to lose 5 pounds. You can guarantee that you'll only have 1 soda a day, or that you'll cut back to 1 or 2 small things. So working with a patient to get to an actionable baby step that the patient feels they have enough control over. And then again, that efficacious kind of building upon it that lets them realize that they can handle this. I worked with a team at UNC, and they used a really brilliant model on clear, helpful communication. It was with congestive heart failure. They used a green, yellow, red light model. And so they had 3 different things. They had swelling, like appendage swelling, shortness of breath, and sleeping. And so in the green pictures, it was like, you don't need to worry if you have no swelling, no shortness of breath, whatever. But then when you get to yellow, it was like, if you're having some swelling in your ankles, if you're beginning to notice some shortness of breath. And by the time you got to the red light, it was like, if you have knee swelling, if you have to use pillows to sleep because of shortness of breath and things, it's time to immediately call your clinic or 911. So even in that instance, and again, going back to the idea there that it is not just for people who are functionally low literate, but for anyone. That's not dumbing down information. I don't think anyone at any education or intelligence level would not appreciate something that clear. This is, your need to know and your need to do. So the only other thing, okay, sorry, I thought I was short on time. So I talked about numeracy being another hidden thing for health literacy and another facet to that thing. You have to be able to think about things, again, for chronic disease management related to insulin, related to your dosage of your medication. But then also you have to think about, we did a big study where we showed like 500 or 250 patients a nutrition label from a Pepsi bottle. And we asked them how many grams or milligrams of whatever type of gram, carbohydrates are in this bottle. And 36% of the people that we interviewed, and these were all different SES backgrounds, all different education levels, said the right amount, because the number that was on the thing, it was actually for 1 serving, but the full bottle was 2 servings. So those are some things that we probably take for granted, but those are very important numeracy skills for chronic disease management. I mean, looking at sodium levels for patients with chronic hypertension, those kind of things. Numeracy also plays a really direct role in medication adherence and medication error. Medication error is one of the most costly and one of the most deadly things in America, and it's often inadvertent error. A lot of times language like twice daily or 2 times daily. Well, patients sometimes think twice daily means that you're taking 2 pills at a time, or there can just be, the labeling itself can be confusing. Sometimes those warning labels can have pictures on them that who knows what they were thinking when they put a picture. I will never forget, there was this one warning label I saw, was for like an oral cream, and it had this kind of outline of a person with these radiating things kind of coming out of it. And we asked a couple patients, and one patient said, "Don't touch that." And then another patient said, they're having an experience with God. And when really it was, just an ointment for ringworm or something. So anyway, but medication and not only the text, but the numeracy skills involved with that are really important. A lot of the work that I did in Chicago was around trying to be more clear with prescription medication labeling. We actually worked on a project with Merck to do kind of a matrix on prescription labels. So there'd be like morning, day, and night, and then the number of pills that you needed to take. But there's still a lot of things to consider when you're having your direct interaction with your patients about trying to empower them to ask questions of their pharmacist, ask questions if they're confused about, if I miss a dose, do I take another one? And just really trying to remind patients that they are in control and the only ones responsible for being able to do that. And that's hard to do sometimes if a patient is, intimidated, and if they do have a lower functional literacy level, or maybe feel just embarrassed or insecure. But that's another area that's really important. And then the only other thing that I'll just mention, just because of time, is the whole new facet of focus on digital health literacy that certainly was present before the pandemic, but of course dramatically increased with COVID, with the number of clinical interactions happening through telemed and telehealth, and then also a much greater reliance on health portals for requesting information like prescription refills or different things. And there's been some interesting preliminary data that's come out. There's a study that is the summer of 2021, some patients at Ochsner in Shreveport, they interviewed about 60 primary care patients, and they said that they loved being able to access portals that you could send a message to your physician and do these things. But some of those patients were like, I don't know how to log into it, I forget my password, I don't know what a QR code is. And to some of us, we think, even though like parking things outside, the first time my mom saw those, she was like, what is a QR code? But so there's an inherent gap there too, between someone's being intimidated by all that is possible in technology, but then also those who are really enjoying it. Then there's also the provider side of things. They've got a much higher influx of inbox messages now to respond to. They've got some other things. And then again, the issue that exists in face-to-face communication and needing to be clear, concise, and caring and understanding. It's a little bit harder to do that through an experience where you're not able to see nonverbal cues and body language and things like that. So digital health literacy is certainly an area and a field that's going to be important to continue to watch how we use language. We don't have to necessarily use the doctory jargon way of saying something to get a really important message across to a patient. So, am I good? I'm good. All right.
You were perfect. Thank you,
Okay,
Kat.
great. Thanks.
We'll go ahead and bring up our second speaker, Robin LeBlanc. Robin is the owner and CEO of a growing CPA and advisory firm in the Broussard area. Her firm has been voted in the top 3 of the Times Best of Acadiana for the last 5 years. So please welcome Robin LeBlanc.
So obviously my background is not in healthcare. But I want to share a personal experience about my interaction with financial literacy and the healthcare industry. So in 2008, I was blessed and gave birth to a beautiful baby girl. Now at the time, I was unemployed, my second attempt at college, and I currently had no plan on what I was doing. I was broke. Fortunately, I had the benefit of qualifying for Medicaid for myself and my daughter. It was good. It was health insurance and co-pays that I could afford, 0. And it helped that I liked my doctor. Fast forward a few years, and I graduated college, passed the CPA exam, and got a fancy adult job. I had made it, kind of. One day I got a wonderful phone call from the Medicaid office letting me know that I no longer qualified for my beloved free health insurance. What was I going to do now? I could hear the tension in the representative's voice as she was ready for me to curse her out and fight and try to keep my health insurance. But I thanked her and let her know she was the first person to tell me I was above the poverty line. Hung up the phone, sat back in my chair, and really tried to figure out what I was going to do. As a baby CPA, I actually couldn't afford the company health insurance. They don't pay you that much, especially back in the day. And I sat, and I knew I had 2 options. I could be a cash pay customer. Please interpret that as I was never going to go to the doctor again. Or I could get the company health insurance and then not be able to save or meet other needs that I had. So I thought about it for a while, waited a couple of weeks, and I broke down and got the health insurance through the company and simultaneously asked for a raise. Because I knew that my toddler needed medical care. It was a couple months prior that she had actually fell over and busted her head straight open on the corner of a glass table. At the time, that cost me 0 out-of-pocket money. But what was I going to do if I didn't have health insurance in the future? So now let's move forward. I got my fancy health insurance, and it's the good kind, the Blue Cross. Doctors like that better than Medicaid, from what I'm told. But I like to keep my life spicy. So I quit my job. So I was back to being unemployed with no plan. So having no insurance and being a little bit broke, as a college student, mom, single parent, that was a little bit acceptable. But now that I was a distinguished professional, it wasn't okay. At least that's how it played out in my head. I was very embarrassed. What was I going to do now? Because I knew I couldn't afford to go to the doctor. How did I know this? Well, why would I need health insurance if going to have an annual exam was affordable? And after I had my pregnancy and my doctor gave me a wonderful implant, he made it very clear that I needed to go to him regularly. But I wasn't really worried about that. I was worried about the money in my bank account and whether or not I was going to meet my day-to-day needs. So we went without health insurance for a while until things changed, my circumstances changed, and marketplace insurance came around, which I'll be honest, a lot of those options aren't very good. So we were able to get health insurance later, and then, we are where we are today, and things are better. But in coming here and working with this, I decided, you know what? Let's actually do some research and find out what would it have cost just to go to an annual exam, get a physical. $202 is the average. I was shocked. I honestly, in my head, in just full lack of knowledge and ignorance, thought it was way more than that. I thought it was closer to $500 or $700, but it's not. $202 comes out to $17 a month. What would I have done if I was able to go have a conversation with my doctor because I wasn't embarrassed? And I would have said, hey, do you have payment plans? What options are available? How much does it cost to actually pay cash out of pocket? These are things that I didn't know. And understanding how much health care costs is taught in school right next to understanding the tax code and how to change your own oil. So even though I was super book smart, I was worldly ignorant. But now that I have the opportunity to deal with individuals on a day-to-day basis and understand their financial history and their financial insecurities, a lot of people are uninsured, and a lot of people are just not going to the doctor because they know in their head how unaffordable it is. So I am requesting that everyone give some sort of transparency and being able to talk to your patients about it before it's necessary. Are you in a position to put in your offices or in pamphlets or on your websites what options you have available for people to pay out of pocket? And be the first one to start that conversation before it becomes necessary, so that people are available and that door is already open for them to communicate with you when necessary. In the last several years, we've seen inconsistencies in jobs and employment and income. And even before that, locally, with shifts in the oil industry, there has been unemployment and loss of insurance when workers are out of jobs. And oil industry is a big portion of our population and a big portion of our insured workers. So please, I ask you, don't let other people be like me and not be willing to engage in medical care due to lack of knowledge and ignorance. Open that door and be transparent. Thank you.
Thank you, Robin. We'll go ahead and introduce our last speaker for this portion, Dr. Taniecea Mallery. Dr. Mallery serves as the Senior Director of Equity, Diversity, and Inclusion at the Association of American Medical Colleges in Washington, D.C. Took the flight down, yay. In this role, she helps guide senior leaders and chief diversity officers at the nation's medical schools, teaching hospitals and health systems to build more inclusion in these organizations. Please welcome Dr. Taniecea Mallery.
Well, good morning, and I'm really excited to be here and really was impressed by my fellow panelists. So just really excited and honored to be on this esteemed panel and sharing just a few of my thoughts with you today. I am working at the Association of American Medical Colleges, where I've had the opportunity for the past year or so to really dive deeply into academic medicine. And before that, for about 7 years, up until about a year ago, I worked at the University of Louisiana at Lafayette as their chief diversity officer. So spent a lot of time in higher education thinking about diversity, equity, and inclusion, both in academia and now in academic medicine. One of the things that I reflected on as I was preparing for this conversation today is March 13th, 2020. It's a date that I'll always remember. I see some nods. I think many of you will always remember that date. I was sitting in my office at UL in Martin Hall, which happened to be right across the hall from the president's office and right next door to the provost's office. So I started to see a flurry of activity in the hallway. And I'm like, something's going on. I don't know what it is, but there's a lot of activity and a lot of important people are talking about it. Certainly, I very quickly found out that, as all of us found out, that we would be turned upside down and had to completely shift our entire lives to a remote and digital environment. And in higher ed, as you can imagine, that was quite a heavy lift, as I'm sure it is in healthcare as well. All of our instructors, our faculty, had to, within 2 days, shift their entire curriculum from an in-person delivery to an online delivery model. And as you can imagine, there was a wide range of experience, comfort level, excitement, about shifting into that digital space. A lot of people, some people were very comfortable and had been teaching digitally and virtually for forever. But there were a number of people who had never taught in a virtual environment. And to have to flip in 2 days and figure it out, I mean, you can imagine that's pretty daunting. And so what we had to do at the university was to create resources within our distance learning department to equip our faculty and our students, who many of whom also had not engaged in their classrooms digitally and virtually. And that was quite an experience. And I'll have to say, I really gained a much deeper appreciation for digital literacy, and I think an even better term, digital equity and inclusion. I think I really appreciated Kathryn's point, and I think it came up in Robin's remarks as well, that literacy goes far beyond education and know-how. right, it really gets down to access for me. When I thought about our students at UL-Lafayette, who I would hear stories about how they would drive to find hot spots in parking lots because they were trying to finish their homework and they didn't have access to high-speed internet in their hometown and their communities. A lot of our students came and commuted from rural areas that didn't have that access. And it really got me thinking about this question of digital literacy as really a question of digital access and how much access do we have in our communities. I mean, the fact is, we don't have very good broadband access in our rural communities. Now it's getting better. I think there's a lot of good news when it comes to the federal government. We heard a couple months ago the Vice President, Kamala Harris, was visiting Sunset, I believe it was, to talk about quite a bit of investment that's being done in our rural communities to increase access to broadband internet. And when I think about that, that directly ties to digital equity and literacy to me. That is a direct line of access for our populations that are most underserved and most vulnerable to not having the access to the health care that they need when we're moving into a world that is increasingly digital. I think one of the lessons that we've learned from the pandemic is that we're moving into more digital living and life in a digital world. And so I think as we continue to shift down that paradigm, I think it's going to be increasingly important to teach, to expose, to create more infrastructure, to create that access. And I'm really excited about the emerging opportunities that that's going to provide for us, both in education and in healthcare. One of the stories I wanted to share with you, I recently, one of the panelists spoke about this generational divide. Right? I won't date myself, but I will say yesterday I was carded at the store, so I will take that for what it's worth. I grew up in a time where I was in college when Facebook was released, and as if you remember, for those of you who are familiar with Facebook, when it was first released, you had to have an EDU email address, a college email address in order to get access, and I was a freshman in college, so I was one of the early adopters of Facebook. So, very familiar with digital tools and being online. I also lived in Washington, D.C. for a number of years in New Jersey, so very familiar with big cities and all of that. So a couple of weeks ago, my parents were taking a trip to New Orleans, which is not that far, but they wanted to use Uber. And they're in their mid-60s, which admittedly I'll say is pretty young. I'm sure there are some of you in the crowd who would agree with me. But they had no clue how to use Uber. And so I literally had to sit down and walk them through downloading the app, and it's very intuitive for those of you who have used Uber before. But it was not a matter of, my father is one of the smartest people I know, so it wasn't a matter of education and know-how. It was just that they had never had the reason to use Uber. And so I really want us to get into thinking, how can we both create an infrastructure where we're creating access to these resources and tools, these digital tools, but also thinking about how we educate and how we expose people to new things that they just have not had an opportunity to use before. And it just opens a door to them for really creating more opportunity and a better life for all of us. So I'll stop there.
Thank you so much. While you were talking about your parents trying to navigate Uber and then you teaching them through that process, I just remember 3 months ago helping my mom with my charts. She's probably in the crowd. Hey, Mom, wherever you at? Trying to help her navigate my chart. And I felt so, I guess, for lack of a better word, incompetent, because I'm thinking, I'm 25. I grew up in a digital age. I should be able to know how to navigate this and help her out and make sure that she has all her needs met. Could not figure it out.
Yeah.
Had to call customer service.
Yeah. Oof.
It just wasn't working. So I can only imagine somebody who is twice my age, triple my age, looking at this and being very intimidated by the whole process. Absolutely. So can you all talk about, how this digital divide affects, the health outcomes for some of these patients?
Absolutely. Well, that's a perfect example my parents are also, both have Seminole degrees. They're professionals. They cannot figure out how to log into their portals, and I'm showing them I have a MyOshner app, and I'm like, oh yeah, I got my lab results, and it's very intimidating, it's demoralizing is too strong of a word, but it's it's frustrating, and it makes you feel less in control of your health. So I think it directly affects that, and then this is a little tangential, but the comments that were made earlier related to Dr. Google and to using the internet for these things, what a lot of that generational gap is really good at is knowing how to Google works. So they may not know how to get the actual health information from their actual doctor who ran the actual labs, but they can for sure go to that search bar on Google. So I think that's a really important communication thing too to keep in mind, is to have reputable, informative websites or organizations or things, because that plays into this whole digital literacy too, to be able to say, and there also are a lot of scenarios where there is distrust of even some of the reputable government websites or places that previously may not have been questioned, and there was confusion sometimes, and there were mixed messages sometimes, and so sometimes I think, particularly when I think of like my parents' generation, it's very important that their doctors say, here, and here are reliable forms of information that you can access digitally.
Yeah, and I think too, who delivers the message is important. I think we really came to discover during the pandemic that, when you want to convince people to change behavior, I think, a lot of that is trust, centered in a sense of trust. And so understanding who those community partners are that are important, who have the messages that will resonate with the patients themselves, I think is so important. I think about our clergy. I think about, our school systems. I think about, all those community organizations that people are a part of that really are embedded with their family members, their community members, the people they know, and those are the people they trust. Right? And so if there are healthcare professionals in your family, I found a lot of times, if you call up your dad or call up your sister or your aunt, my husband happens to be a nurse anesthetist, and I can't tell you how many times he's like, call a nurse, like phone a friend. People are calling him all the time, like, with their health issues. So it absolutely, there's this sense of trust and communication of who can you go to get the important information that you will then act on in order to make your health outcomes improve.
And just commenting on your experience with My Charts, it's also understanding what the actual customer experience or the client experience looks like, because when it comes to technology, what you're seeing on the back end isn't necessarily the same thing that they're seeing on the front end. So whether or not it's calling the doctor's office or customer support, like, you should be in the position of, when you're doing or providing a service and providing that user experience, it's not just about your experience on the back end if the patients themselves are not actually able to utilize it to its full benefit.
And you touched on this as well, Robin. Most times people are hesitant because of the cost of medical care. They have no idea until they look it up, or once they get to the doctor, they see this huge bill, and all they had was maybe a checkup or something. Right. So kind of to talk about, medical debt, are there any options available for patients where they could alleviate some of that the common person may not know are available for them?
So part of that is going to be on what is offered by different hospitals. I know some hospitals have it available that you can do blood donations that actually get your bills down. But how often is that communicated? And what do individual places have, whether it's discounts for cash-pay customers because you're utilizing less resources internally than fighting with insurance companies? So is there any benefit from that? Or something like payment plans. I remember between all switching insurance a dozen times, that my dentist's office was like, yeah, we don't take that one, but we have our own program where you can pay X number of dollars a month. And I was like, sign me up. I'm not leaving you. And so, I was able to do that at that time. And it's even coming up with something unique to you. And now they have care credit everywhere has become very popular over the last couple of years. So it's a lot of it is communicating options and finding out what other options are available or creating them.
And I would just add also, absolutely, but also, again, so much of, I think, a takeaway from this whole experience today in this summit is a desire to empower patients to play a role in this. So I know I'm always intimidated to ask about the cost of something. I had to have an MRI a couple of months ago, and in my mind, I'm thinking, I really kind of want to ask ahead of time to run this and see what it is, because I know a lot of times the clinicians do not know what it's going to cost. They may know who your insurance provider is, but they don't know often exactly how much a lab or an imaging is going to cost. And I remember being really intimidated by it, and my sister is a nurse practitioner in another state, and she was like, well, call the place. And I was like, oh, yeah, I could just call the place. And so sure enough, the place that I was going to go to, I found a $500 difference in 2 locations. And yes, it took a little more time, it took a little bit of problem solving there, but if you are able to empower regardless of your interaction as a social worker, as a front desk person, as a nurse, as a physician, whatever your role is, if you work towards giving them that authority and empowering to just say, look, just because a price is a price, you can still ask questions, not only about payment plans, but differences, price differences. I shop at Target for some things and Walmart for some things. I'm going to get an MRI here and an MRI here.
I think that's good. That covers it.
Everybody's bases are covered. So kind of to move into my next question, it's something that's been coming up for every single session, even in the mini documentary. People who had Medicaid, they were automatically stigmatized in a way because they didn't have Blue Cross or any other type of coverage. So how can we kind of mitigate that stigma of what type of coverage people have?
Yeah.
I was just thinking, I was like, that's a good question.
That is.
Oh.
I thought you had a good answer.
No. I'm having some reflection moments. Yeah. I mean, there is a stereotype with it, and I know even in my own personal, so right now, we have, goodness, what insurance do we have through my company? Blue Cross, but for whatever reason, my daughter still is covered on Medicaid. I haven't figured out why, and I'm not complaining. But I still, especially being in my industry and the connotation that comes with my reputation, I don't tell people I have Medicaid. Unless it's okay, well, this is how much it's going to cost, Blue Cross, blah, blah, blah. And I'm like, all right, well, but by the way, some after the fact note, let me slip my Medicaid card in there if you accept it, but I'm not going to tell you because I don't want you to think of me in a certain way. And I'm just still waiting for it to just magically go away. I don't know why. But even I myself have, to me, that connotation where Medicaid's for poor people and I can't afford it, and it means you have this income level. But it's also about being able to treat people with respect and not showing it it's a bad thing. And the insurance, from my experience of dealing with from the financial side of businesses that take Medicaid as opposed to other insurance, it's also a different level of care that's received due to the quantity of Medicaid patients you have to see in order to make the same amount of money as private pay. So even from that aspect, they're being treated differently without it even being a stigma. And I know that doesn't kind of answer the question.
No, but that was actually something I was going to bring up about it, is in a clinical setting, there are some things, just the same way that sometimes if a clinician walks in and sees a patient who's, extremely overweight or has some other health thing that you can immediately see or notice, there is sometimes a difference, a posturing that is different with a physician, because they're like, oh, well, this guy smokes, so blah, 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 you know? There's something like that. And that's the same thing, I think, when it comes to things related to Medicaid. Certainly not all clinicians are this way, and there are wonderful clinicians who care for Medicaid population and have this great care that is provided. But it is something that is, you know, on a subconscious level. Sometimes it's just sort of like, oh, well, you're not trying to get into any kind of different situation, so I'm going to spend even less time talking about what you can do to help benefit your health or whatever. So.
Well, and it has a real impact on healthcare delivery.
Absolutely.
You know, I think I'm thinking of one of my colleagues who works at the University of Michigan Medical Center, and I just learned that she's starting a new project on inclusive language in the clinical setting. She's been examining, she created case scenarios where she broke down the language that was very stigmatizing within sort of the direct patient care environment in the ER, and she's noticing some real disparities in terms of the health outcomes based on these assumptions that people make, looking at a patient, thinking about their lived experience and how that's impacting the quality of information they're providing to their clinician, that's leading to real change in the way that you're treating that patient based on someone with a different background. And so this is, I mean, we could have a whole day conversation about that, but I think it's important to bring that point up, and I'm glad that came up in the discussion.
Is there like a breakdown in just communication as far as what's going on with the patient, but sometimes it could be like cultural barriers as well. So can you guys talk about how healthcare providers can better communicate when, they're meeting with somebody who may be from a different background?
Yeah, I think when I think about culturally competent and sensitive care, I think about families. My current boss is a family physician, and that comes up a lot in his demeanor. I mean, I think it influences how he is as a person, and I've really learned a lot from him. But I think a lot of what we do is thinking about how our family influences the actions that we take. And a lot of, when I think of any medical procedure I've ever had to do, my husband, my parents were always involved in that conversation, in the actions that had to ensue, or the treatment plans. And so, thinking about those individuals and the family backgrounds that they have, what are their, what do they hold dear, what's important to them, and how does that influence the way that they'll behave in terms of the treatments that they need, the care that they need, the types of health behaviors that they need to make, and really involving the family as all being part of the team. I think, we're moving absolutely to a team-based model when it comes to providing care, but also we should think about, receiving care as a team-based experience as well. So I think that can go a long way in terms of increasing the cultural sensitivities.
And I will say another really positive thing that's happened over the last several years is a lot of the curriculum that is taught in nursing school and medical school includes a lot of emphasis on cultural competency and on the importance of recognizing the very different sets of ideas and cultural priorities that come into it. And that's something that wasn't always included in curriculum for students, for physicians. And so, that's a really positive thing.
And this also shows why having a diverse workforce from different backgrounds come into play, because you have somebody on staff who potentially can relate to somebody, especially when there's breakdowns in language barriers, where I know in my profession every once in a while we'll get Hispanic-speaking or Spanish-speaking clients where they have a child coming in to help interpret and get things done. And something like the medical profession where you're using the words that are in Latin or different language and not as easy to translate, especially if the person is a younger child, then having somebody on staff that helps break down those barriers and stereotypes.
All right, we're good on time. So thank you, ladies. Give them a round of applause. We definitely appreciate your time today.